So, good evening, friends. Okay, warm welcome from IPNRC. We welcome you all to this second last edition of Advanced Pediatric Pulmonology Clinic for 2025. As usual, we'll be discussing a case which is being presented by pediatric pulmonology resident. The expert is Naveen sir from Rainbow Hyderabad, and it will be moderated by Dr. Kamal Singhal. Sir, please take over and start the case, sir.
And we have one more lead discussant, Dr. Vijay from
Okay.
Kochi Kamakochi Trust Hospital.
Okay. Yes.
So I'll now thank you, sir. So now we'll request the presenter, Dr. Manmeet, to please start with the presentation. Thank you.
Thank you. Hello, am I audible, sir? Should I begin?
You are audible. Slides are visible. Please start.
Yes, sir. Very good evening to all of the esteemed faculty members and panelists present out here. Thank you in advance for providing me the opportunity to present a case in front of all of you. I hope I'll do the justice. Today we'll be discussing a case which I have titled A Tale of Breathlessness, Unfolding the Clues. Myself, Dr. Manmeet Singh Khalsa. I am DM Senior Resident First Year in Department of Pediatric Pulmonology and Intensive Care Unit at AIIMS Rishikesh. My mentors for today's discussion will be Professor Meenu Singh Ma'am, Executive Director, AIIMS Rishikesh, and Dr. Vyas Kumar Rathore Sir, Assistant Professor in Department of Pediatrics, AIIMS Rishikesh. So, our patient was Master A, 16-year-old male child, resident of Bareilly, Uttar Pradesh. Informant is patient himself. Date of admission is 16th October 2025 and date of discharge is 23rd October 2025. So the chief complaint of the patient was fever, cough, and shortness of breath since 2 years. So coming to the history of presenting illness, the history starts way back in October 2025, where the child was having occupational exposure. Actually, the child was a resident of Uttar Pradesh, but he went to Gujarat to work in a factory where there was polishing and manufacturing of nut and bolt was done. The child had started complaining of fever. Fever was insidious in onset, intermittent, documented to be 101 degree Fahrenheit, associated with chills and occasional sweating. With evening rise of temperature, it was relieved on taking medication and it was on and off. Coming to the cough, cough was insidious in onset, gradually progressive. Initially, the cough was dry, but later on it turned productive and it was scanty in amount, non-blood stained, non-foul smelling. There was no diurnal or postural variation of cough, and moreover, there was no special character of cough. Coming to the shortness of breath, shortness of breath was insidious in onset, gradually progressing.
Hello. Hello.
Hello. Yes, sir.
Hello. We will, Dr. Khalsa, just wait a minute. I think some mic is on. I would request all the panelists who have the mic to please. Yes, Dr. Khalsa, you can start now.
Yes, sir. Sir, should I begin from or continue from
yes,
shortness of breath?
No, from here only. From here only. Yes,
yes,
you have been doing well, and we have got everything what that you said. Please continue from here.
Yes, sir. Coming to the shortness of breath, it was insidious in onset, gradually progressive. Initially, it was MRC grade 1 and progressed till MRC grade 2 more in the last 2 months, and it was associated with palpitation and chest discomfort. However, there was no postural or diurnal variation. The child also has complained of bluish discoloration of fingers of hand and feet, which was more during exposure to cold in the past 2 years on and off, episodic in nature. There is history of significant weight loss, which is documented to be around 12 kg in the past 6 months, beginning from October. There is also history of difficulty swallowing, which was more in swallowing solids than liquid, and it was not associated with pain. So the patient was there in multiple follow-ups in these timelines in November 2023, April 24, May 24, November 24, February 25, and at last in October 2025, patient presented to AIIMS Rishikesh. Coming to the narrative history, there is no history of oral ulcer, joint pain or swelling, hair loss, bluish discoloration of lips, skin tightening, frothy urine or blood in urine, skin rashes, low swelling of lower limb, or no history of TB contact. Coming to the treatment history, sir, for the above mentioned complaint, child was initially taken to a private practitioner and was given some oral antibiotics. However, there was no response, so he left the job at Surat at Gujarat and came back home. In the home, in the month of November 2023, the child underwent investigation where he was diagnosed as a case of pulmonary tuberculosis. As we explored the Nixia ID of the patient, and which revealed that in the month of November 2023, sputum AFB staining was done, which was reported to be 3 plus. However, at this time of investigation, sputum CBNAT and drug sensitivity testing was not done, and the child was started on ATT rifampicin sensitive regimen for 6 months, which got completed in the month of April 2025. However, the child remained symptomatic in terms of shortness of breath, cough, and fever, and the child was again investigated for these symptoms in the month of May, just after 1 to 2 months in the month of May in 2024. And at this point of time, the child underwent sputum CBNAT testing and drug sensitivity testing was done, and sputum CBNAT revealed Mycobacterium tuberculosis, which was rifampicin sensitive. Again, the child was started on ATT in the month of May in 2024 for 6 months, and ATT was completed by November 2024. Since November 2024, also, the child has consulted multiple times at OPD basis, never got admitted in nearby hospitals, but no records are available. No radiological imaging also is with us. However, the symptoms increased in the last 2 months, and in the month of October, finally, the child visited AIMS Rishikesh for his complaints. Coming to the family history, there is no history of TB in family members, no history of similar complaints in family members. The child was also accompanied by his elder brother to the workplace. However, he is completely asymptomatic. Birth history: child is full term normal vaginal delivery, tried immediately after birth, no history of NICU stay, and developmental history is as per age. Immunization history of the patient per se was not aware of his immunization status. BCG scar was although present. Nutritional history: child consumes a mixed diet, and as per 24-hour dietary recall method, he consumes 1400 kilocalorie with deficit of 700 kilocalories and 30 gram of protein with deficit of 10 gram. Now, summarizing my history, we are looking at a case of 16-year-old male child with normal birth and developmental history, presented to us with complaint of fever, cough, and shortness of breath for 2 years, with history of difficulty during swallowing and bluish discoloration of fingers on exposure to cold for past 2 years, with history of occupational exposure to heavy metal, and also history of microbiologically proven Mycobacterium tuberculosis, twice treated with ATT with good compliance.
Thank you, Dr. Khalsa. I will just ask you to wait here. We have heard the history. A lot of information has been given. Let us try and assimilate that. Let us try and bring in the lead discussant at this point of time. I'll first request Dr. Vijay to please come in, and if you have any questions which are unanswered or any comments or suggestions, let's start the ball. Let's proceed with that.
Yeah, first we'll go to the first slide, which he was showing as a graphical representation of his symptoms. So the first symptom is fever, right? So how was the fever? Whether it is like he's having every month or it is only one episode, and how many days it was lasting, and till now for the last 2 years, how many episodes of fever he had, whether he had any response with the treatment of ATT. And so that's the first one. So we'll
Yes.
decode each symptom, how it is.
Yes.
Was there and now it is now.
Yes, sir. Initially in the month of October, sir, the child was having high-grade fever with chills and sweating, and also there was evening rise of temperature per se, for which he consulted at OPD basis and was told that he was having some kind of typhoid fever and all. Although records were not available, however, his symptom persisted, sir. Per se, the fever over the past 2 years, since when he consumed ATT for the first time, also there was partial improvement in terms of fever only. However, cough was persistently there, sir. The response to ATT twice, which the child has consumed with full compliance, was partial response was there, sir.
Apart from that, he was having fever in between.
Yes, sir. In between, the child was having fever, sir, but not per se documented, sir. In For 2 to 3 months, that fever subsided, but again came back, sir, during the treatment as well.
No, that we don't know, no, whether it is because of the primary disease or it is some infection anyone can get once in 3 months, some fever, cough, cold. That we don't know whether it is really related to the current illness, that is the progressive illness, or it is some infection which is getting transmitted in the community. The second one is cough. You said it is insidious gradually. So he was having daily cough.
Yes, sir, sir. The cough was, sir, not per se daily, but the child has never been completely void of his symptom. There was no occupational exposure per se of after the month of November. So the child left the job, but still he was having cough, sir. There was no
Okay.
exacerbation and no special character of the cough was there. There were no seasonal variation, and the in between, sir, child was also given nebulization trial, but it wasn't responding, and there was no history of cough on and off previously. Previously, child was asymptomatic, sir. During this episodes only, he was having cough, sir.
Okay. During fever episodes, his cough was increased. That's what you meant to say, or it is
Yes, sir.
okay. Okay. So it
Okay.
is only an exposure to cold is getting blue, or after some time when he got admitted with you, you can able to see some cyanosis of peripheries. Like,
Uh,
is there any complaint even without exposure to cold?
Sir, with cold only per se, the complaints were there, but on presentation also the child was having cyanosis, sir. In the upcoming slides, I'll show, sir. There was some cyanosis evident. Blue discretion was there, sir.
Okay.
But the child
And
could appreciate that only on exposure to cold, sir.
this difficulty in swallowing also, it
And
is for the last 2 years.
yes, sir. Yes, sir. This time also, this time only the child specifically told that there was a feeling of some things when during swallowing there was a sticking of food to the
And
means.
it is always only for the solid food.
Yes, sir. More for solid than liquid, sir. More for solid than liquid, sir.
Okay.
I think one of the questions which probably we could ask is I think the kind of very different symptoms, isn't it? The kind of constellation of symptoms here, isn't it? And I'm very interested in it. You started off with occupational exposure rather than the fever, isn't it? That was pretty much your first few
Yes, sir.
things you presented. So were you thinking that it was a thing of significant importance at this stage?
Uh, yes, sir. Child has been working for past. There was a history of exposure was for past 1 year, sir. The child was working in that factory where these symptoms were when he started having symptoms, sir.
Any clues, think from the polish you talked about polish and nuts and
Yes, sir.
bolts? You think anything, any clue in the occupational history at that point, at least, when you first took the history?
Yes, sir. Sir, the child was working in a factory where the polishing of the fine refining of nut and bolts was done. So we expected that maybe there was some inhalational type of thing going on, sir.
Okay. What polish do they use?
Pneumoconiosis related, yes, sir.
Yeah. What polish do they use for nuts and bolts?
Uh, Sir, it was not chemical per se. There was grinding of nuts and bolt to polish them. Not per se that chemical like thinner was not used, sir.
So more
But
of a
grinding,
more of
yes, sir. More of iron means you can say
a physical grinding.
yes,
Okay.
sir. Grinding was there, sir.
Okay. Okay, that's one. That's an interesting point. And the second you talked about swallowing also, did it stop over the last 2 years, or it's got worse or better, or what's happening with that?
Sir, per se, the this complaint is bare minimal, sir, only because when we looked at the investigation finding and then we retrospectively saw that the child's esophagus was quite dilated, and that gave us a clue that might be will be missing
What
something, and
Dr.
that's
Halsa,
why.
what everybody is trying to ask is actually we will not talk about investigation and examination here. The point is
Yes, sir.
whatever symptoms you described, are they progressively worsening?
Sir,
Be it
shortness.
dysphagia, be it shortness of breath.
Mm.
It could be something like it started at some point of time and it has been persisting since then like that. But is it worsening? For example, dysphagia. There is a question in this chat box. Is the dysphagia worsening further, or is it the same what it was?
Dysphagia per se is
Static.
static, sir. Only the shortness of breath was the main concern.
Which has been progressively
Yes,
increasing,
sir,
that
which
we
has been
understand.
progressing from MRC. Yes, sir.
And how about this discoloration? How does it resolve? Is it just related to cold, or in between periods also he is blue? Parents, have they noticed that the child's fingertips otherwise are also looking a bit blue or swollen? Because intermittently getting blue on cold is one thing, but otherwise also being blue, or say swelling of the fingertips, it may be there on history, or they may not have noticed it, but that's what we wanted to ask.
No, sir. In the past 2 years, they were saying only during exposure to cold per se, more in winter season, and also when he was outdoor working, only then they have noticed, sir.
So when the parents say no,
And,
which means that maybe there could be something on examination which they may not have noticed.
noticed,
This is
yes,
something
sir.
that you will better
Yes.
elicit on an examination rather than history. But what we now know is that a 16-year-old child, if just correct me if I'm wrong, who has symptoms for the past 2 years, which are more or less progressively worsening in terms of respiratory illness is worsening with time. Dysphagia is there, which has been persisting. Weight loss is there. And then you have microbiological evidence of tuberculosis. Once only FB, and second times you have a genetic test also, which tells you this. So, and throw a bit more to this, you say there is some occupational exposure. We are not exactly sure what chemical, what it was. There could be things which we may not be aware of. And and this bluish discoloration or and cold. So these dysphagia and bluish discoloration to cold, these are two things which are very uncommon. Otherwise it would be it's a common scenario that we see, but these two things make it different from what we usually see. So but what do you think, what is your thought process here now? Now you have summarized the case. Anything else that you wish to add?
No, sir. In
This is it.
history, I'll stick to it.
Perfect.
Yes, sir.
Perfect. So what thoughts came to your mind? What do you think is the most likely cause at this point of time? Okay. Yes, you can show the differentials table.
Yes, sir. Sir, the first possibility which we kept was connective tissue disease related interstitial lung disease, sir. Points in favor of this diagnosis are there is a certain evidence of hypoxia, sir, clubbing, Reynolds phenomenon per se, and there is also dysphagia. Points against this is that there is history of microbiologically confirmed tuberculosis on testing, sir. Second possibility which we kept was Welder's lung or iron exposure pulmonary cirrhosis, sir. Points in favor were only the history of exposure and temporality of symptoms, sir. Point against this were there was fever, Reynolds phenomena, dysphagia, and also weight loss, sir. Third possibility which we kept was hypersensitivity pneumonitis. Points in favoring our diagnosis was history of exposure and temporality of symptoms, sir. Points against was Reynolds phenomena, dysphagia, not relieved after quitting job, even after roundabout for the past 1.5 years. He has not been exposed, but still there is sir, evidence of hypersensitivity pneumonitis, sir. The fourth possibility which we considered was post-TB sequelae per se, chronic cough bronchiectasis like kind of presentation, sir. The points in favor were history was suggestive of this chronic fever, cough, shortness of breath, and also there was microbiologically proven tuberculosis. Points against was that the pus was initially non-productive to start with, and also there was Reynolds phenomenon and dysphagia was present, sir. Very
So I
loud.
think that's a good differential, Dr. Manmeet. I think, and you also talked about MDR TB, isn't it, as a
Yes,
differential
sir.
right at the bottom.
Yes, sir.
But we've had no evidence in the tests we've done so far of
Mm,
MDR TB.
no, sir. No, sir.
Fine. So, so you've got a nice set of differentials there. Is there a possibility that there could be two pathologies in this patient?
Uh, yes, sir. But our first differential per se would almost consider it could be, sir, that we cannot deny per se the microbiologically proven that too twice, sir, of tuberculosis. That could explain this, and also we can say that maybe tuberculosis was a second hit on underlying intestinal connective tissue disorder, and leading to its exacerbation per se, sir.
Or could be the first hit also. We don't know, isn't it, at this
Yes.
stage?
Yes,
TB could have been there for a long time. So I think one of the things here is, so yeah, you're using Reynolds quite often. It's Reynolds, Raynauds, Reynolds phenomena. It's not Reynolds. Okay. So just to correct that. So
thank
as
you.
Dr. Kamal said, it is quite rare for these two symptoms, your dysphagia and your Reynolds phenomena to be there in children like this, really. So I think that makes it very interesting. And I think what are the differentials from a connective tissue disorder, you think? From the top differential, the one you put first, Could you have a further differential within that? What does it fit in with? What type of connective tissue disorder related ILD? What type?
Sir, we were thinking about sir, maybe systemic sclerosis, sir, and Georgian syndrome, sir, and like this systemic sclerosis and Georgian syndrome were the first two, three go to in connective tissue disorder which we were keeping, and also we also kept the possibility of SLE per se, although it's a male child, but still we can also consider SLE also.
And what would lead to the weight loss, which is significant even now in just a systemic
Yes, sir.
sclerosis? Is it the other disease, or is it not able to swallow, or what do you think? What was suggested? Because I think in the history itself, I think this child was properly treated for TB and all that.
Yes, sir.
Twice, if it was TB, he probably would have improved. But he never improved, actually got worse and lost 12 kilos of weight, isn't it? So I think what led to the weight loss? I think do you think?
Per se, sir, nutritional history also points towards the thing that the child was perhaps a bit malnourished, sir, and also, sir, we think that maybe the first hit of tuberculosis was there, sir, as per my statement, sir. The initial weight loss which was present in the first period of first 6 months only, that was significant weight loss, and that I attribute most probably due to tuberculosis only, sir.
Okay.
The feeding difficulty was there, sir, but per se during hospital stay also we inquired about his dietary habits, so he was consuming adequately, sir.
But he had a 700 calorie deficit.
Yes, sir. Yes, sir.
Over a period of 2 years, that is significant weight
Yes,
loss,
sir.
isn't it?
Yes, sir.
Maybe nutrition also, isn't it?
Nutritional.
On top of everything else going on. Yeah, Dr. Kamal,
Yes.
Dr.
So what I feel here is see, we have a microbiologically proven TB, so nobody can negate that. It's there playing somewhere. Now, the history. The interesting thing about history is that one thing you twist to other side, everything changes. For example, are you very sure this is Raynaud's phenomena when you say there were episodes of bluish discoloration? I'll tell you why. A child can have respiratory distress because of respiratory cause. He can have a respiratory distress because of cardiac complications also. If somebody has a chronic complication like this, we believe he has some interstitial kind of an involvement here. If it has to explain all the weight loss and shortness of breath and everything. And a very common complication that we see at the end of it is a pulmonary artery hypertension. And you can have crisis in pulmonary artery hypertension. So and this is something that has to come from history. Are you sure this is Raynaud's phenomena, or is it something like a pulmonary hypertension where in between he has those crises where he gets blue?
Shunting, yeah.
Dr. Khalsa.
Yes, sir. Sir, per se, sir, it's very rightly pointed out by you, sir, that it could be episodic pulmonary hypertension crisis, but there was occupation. There was history also showed that it was only on exposure to cold per se, sir, during the daytime per se, and during the non-winter season, sir, it was not there. So that made us think more in terms of Raynaud's phenomena, and also per se, sir, dysphagia was also there, so that made it more inclined towards keeping it that maybe it was Reynolds only, sir. But
Perfect.
per se,
so other thing that we were discussing was about weight loss. I think when you say nutritionally, it should mean that lack of nutrition is the reason why he's losing weight. But here, in such a scenario, for example, if a patient has TB, his nutrition will also be, he will be taking less food just because he has TB. It is not primarily deficiency of food. It is a systemic disease which is making him take less feed. So in a child who has, suppose, interstitial involvement, who has such distress, his caloric requirement will be much higher than what that of a usual child. So they will be losing weight, and that's how it is. So in such a child, I think shortness of breath, severe distress, increased work of breathing, all that also contributes to a child losing weight to some extent. But yes, fever running, it could be something, an acute infection. So Dr. Vijay, your thoughts on this?
One thing is, can dysphagia also happen in TB? Maybe a retropharyngeal thing which is causing swallowing difficulty, or some lymph node which is just compressing the esophagus. So it was like, it is not too much away from tuberculosis, since he was by bacteriologically proven tuberculosis. Of course, I agree there is something else is also going on, but it's not entirely against. I feel it is from tuberculosis.
So what we have seen is that TB is something which can when somebody has an acute TB, he will have all those complications of fever, weight loss, decrease appetite, and so on. But once it results in those sequelae kind of things, like it can result in interstitial involvement, it can result in a fibrosis of the lung, it can result in bronchiectasis, where they ultimately end up a child who is having severe distress and not gaining weight, not because he has an acute infection, but because the lung is so bad and so damaged. So a TB can also explain a lot of things, but yes, dysphagia is a bit difficult to explain. Then it is so rampant in our country that you name an uncommon presentation and it can still be somehow explained with TB here. But yes, it's an interesting presentation. Should we proceed with the examination?
Yes.
Yeah.
I think yes, Dr. Khalsa.
Yes, thank you, sir. Examination on presentation, vitals of the patient were as follows: heart rate of 112 beat per minute, respiratory rate of 23 per minute, saturation of 89% on room air, and blood pressure was 110 by 64 millimeter of mercury, and temperature was recorded to be 99 degree Fahrenheit. General physical examination, pallor was absent, icterus absent, cyanosis was present, clubbing was present grade 3. There was no significant lymphadenopathy, and edema was absent. These are the photograph. These are not of presentation. These are the photograph per se during the hospital. During means now the child has been discharged. Now these are the latest photograph. In these also, I think we can appreciate that there is definitely some clubbing is present, probably grade 3, and also a bit cyanosis. I don't know whether if only I am able to make out or is it present or not. There is some bluish discoloration of fingertips.
Pictures are difficult to it will be difficult to elicit finding. We will believe what you say. If you have seen cyanosis,
It's
it
there.
is cyanosis. We would say that there is cyanosis.
Coming to the anthropometry, weight of the child was 46 kilogram, which was less than -3 standard deviation. Height was 166 centimeter, which was between -2 to -1 standard deviation, and BMI of the child was 16.7 kilogram per meter square, which was between -2 to -3 standard deviation, as per WHO standards. Coming to the respiratory system examination, on inspection, nasal and oral cavity were within normal limit. Trachea appears to be centrally placed. Chest wall appears normal. There are no visible scar mark or no visible dilated vein. Bilateral chest expansion appears to be normal, and apex beat was seen in fifth intercostal space lateral to midclavicular line, just lateral to midclavicular line. On palpation, trachea appears to be centrally placed, tensile negative. Bilateral chest expansion was symmetrical, however, it was decreased in the basal region bilaterally, and tactile firmness was equal in all areas. Into the percussion, there was in the supraclavicular and infraclavicular resonant note were heard in the memory and in memory, inframemory, axillary, infra-axillary and supraclavicular areas. There was resonant note heard, apart from the cardiac dullness on the left side and liver dullness.
What we see is that abnormal is only
Yes,
infrascapular
interscapular and
impaired node.
infrascapular
That's
region
it.
impaired.
Rest is normal.
Okay. Yes, sir. Yes, sir. On auscultation, bilateral air entry was present and equal, and bilateral vesicular breath sound was heard in all the areas. In this only, there was fine crackles were heard in the infraaxillary, interscapular, and infrascapular region.
So the abnormal air is in the same place, interscapular. You have crackles where you had impaired node.
Yes,
and
sir.
you have infraaxillary crackles. Rest is all normal.
Yes, sir.
Okay.
Coming to the cardiovascular examination, we were able to appreciate loud P2 and no murmur. Rest cardiovascular examination was within normal limit. There was no per abdomen was soft, non-descending, non-tender, no organomegaly. Nervous system examination was also within normal limit. Now, coming to the summary of examination, here we have a child on examination. The child was having wasting, grade 3 clubbing, cyanosis, impaired note heard in inter and infrascapular region, bilateral crepitation heard in infraaxillary, inter, and infrascapular region with loud P2.
Okay. Yes, I think you can summarize the case and then we'll call and bring in the lead discussants.
Yes, sir. Yes, sir. The case summary, a 16-year-old male child with normal birth and developmental history presented with complaints of fever, cough, and shortness of breath for past 2 years, history of difficulty during swallowing and bluish discretion of fingers on exposure to cold for past 2 years, history of occupational exposure to heavy metal, history of biologically proven mycobacterium tuberculosis, twice treated with ATT. On examination, child was having wasting, grade 3 clubbing, cyanosis, impaired note heard in inter and infrascapular region, bilateral crepitation heard in infraaxillary, inter, and in infrascapular region with loud P2.
Any skin lesions?
No, sir. There were no skin rash or any.
Rash or any
No,
deposition?
sir. No malar rash or no erythematous rash was present, sir. No food system.
So, Dr. Khalsa, there is a question in chat box. Can it be a congenital heart disease presenting with Eisenmangerization? A question to you.
Sir, congenital heart disease per se with presenting so late without any asymptomatic for 16 years, that too without any history of there is per se there is no stunting, and also, sir, no history of repeated hospitalization, no history
I
of
think I agree with you because, for
Yes,
a
sir.
congenital heart disease
To
to
present
present
it,
so late, because
yes,
for him
less
to
than
have Eisenmangerization means he should have left to right
heart
shunt
failure,
manifestations
left to
prior
right.
to that.
Yes, sir.
So if it is uneventful till now, he has not had so much of a left to right shunt, then for him, the shunt to reverse, clinically less likely. Any history suggestive of fingertip tightness?
No, sir. No history of skin tightness, sir. I have
Okay.
mentioned.
So Dr. Naveen, your thoughts on
Yes,
this?
sir.
Yeah, I think your examination probably sits in with your history, really. I think you've got a child has significant wasting and he's got clubbing. So I think, as Dr. Kamal said earlier on, I think that cyanosis and clubbing, it gets a bit tricky at this stage. So you've got very clearly a child who's got clubbing and cyanosis, both probably at rest also, isn't it? So it's not an intermittent cyanosis you talked about, isn't it? It's cyanosis when you've seen the child, isn't it? Or has it been an intermittent cyanosis?
I think initially it was intermittent. Then
Intermittent
let's say asked whether it was there always when you
But I think
saw the
now
child.
that they have when they say on examination, it is there, it is there.
So
Clubbing cannot go off and on.
so you've got established cyanosis here at this
Yeah.
stage, isn't it? And
Yes.
then I was a bit surprised by the examination findings. I mean, you've got a significant history in this child. When you did your examination of your chest expansion, you said the chest expansion was reasonably good. I mean, I would expect at least this child would have a slightly lower chest expansion. Did you measure? It's always nice to measure, especially in chronic cases like these.
Yes, that in an expiratory phase, this many
Yeah.
centimeters, in inspiratory phase, that
Yeah,
can give you a clue.
that can
That
give you
can
a
give
clue
you a
as to
clue.
what type of disease it can be actually. But yeah, that's what you talked about is that.
Not measured, sir, but it was decreased in basal region per se.
And you've got crepitations in the basis, isn't it? Mostly,
Yes.
it's got scapular and all that. I think these kind of points to some kind of interstitial lung disease process, especially your crepitations and all that. The second thing is, could this patient be in a bit of cardiac failure secondary to right heart failure? Because there are signs of pulmonary arterial hypertension with loud P2 and all that, isn't it, at this stage? So
Yes, sir.
from your examination, it sounds like this child is quite wasted. And then you've got some kind of a crepitation-driven lung disease, especially in the bases, isn't it? More than the episis. We don't know about the chest expansion, but I assume probably it would have been reduced at this stage. And then you've got very clear signs of pulmonary arterial hypertension, whether it's secondary to the lung disease or otherwise, we don't know as yet. But I think it points to that, isn't it? So chronic lung disease with interstitial pattern, and you've got a possibility of a pulmonary arterial hypertension, isn't it? Secondary to lung disease, we don't know. But what is also interesting is we didn't find much evidence of if it was a TB sequelae, you'd probably see a bit more bronchiectasis type, lot of low course crepitations and those kind that you didn't find. You
No,
you
no, sir.
find crepitations.
So
And
yes, actually, he is not very clearly said. Was it fine crackles or coarse crackles?
Sir, were fine crackles, sir.
Because that takes you away from bronchiectasis
correct,
towards
that's
interstitial lung disease.
more of interstitial lung disease type of picture, if that's right. Yeah. So I
Dr.
think that,
Vijay?
hmm.
Yes,
And
Dr. Naveen, you can finish.
Yeah,
there is
I think that's it. Yeah, that's it.
Dr. Naveen, should I move to Dr. Vijay?
Yeah, absolutely.
Yes, Dr.
Yes,
Vijay.
sir, there is no clinically at least no fibrosis like tracheal deviation or some differential
No, sir. Take
chest expansion. All these things also not there,
No,
despite
sir.
he was having say
So I think
recurrent TB.
yes. So I a bit of differ here to some extent. For example, what we see when we see TB sequelae very commonly, and what we see very commonly is that in them there is a bit of asymmetry. You will not have findings which are symmetrical.
Yes, yes.
In TB, it is usually the upper lobe involvement more often than any other lobe involvement. And here you see symmetrical involvement of bilateral lower lobes.
Correct.
That's what makes it a bit odd. But in ILD, if you look at the Oscar examination finding, he's wasted but not stunted, or his height is more or less fine, which means had it been an ILD going on for months, we believe that when they start having symptoms which are clinically apparent, there is already something going on for very long. But that would affect the height, which is not affected here. So it's not something going on very it's not something probably which is going on for very long, looking at this enthro. And with this semis findings which say that the symmetrical findings. So I think still I'm not very clear this is in diagnosis. Secondly, one more thing about ILD, if you look at the picture of the patient, it's still the chest looks fine, although this would not be the right view to comment on that. But it doesn't look as that kind of a flat. I may be wrong, because this is not the right way. Dr. Khalsa, do you think that on the look, when you look, interstitial child, you can actually see that his chest excursion is not good? So do you think his chest excursion was good otherwise?
Very sorry, sir. I can't comment on that.
Okay, fine.
Finding
It's always a good idea, because if you expose the child, the kind of breathing that they take, you can make out the excursion is good or bad. Usually symmetric ILDs are usually symmetrical, and post-tubercular sequelae are asymmetric, and you have involvement more of the upper lobes rather than the lower lobes. So in that sense, TB is there. There is no confusion about that. But has it happened over and above something which was already going on? That's the question. TB is not in doubt here. But is there something underlying? 2-3 things make us believe that yes, there could be something going on underlying which can explain all this. Okay, I think let's proceed with your investigations.
Yes, sir.
So any change of differential, just you can comment on that.
No, sir.
It's more or less the same. You have put in interstitial pneumonitis.
Sir, hypersensitivity pneumonitis, sir.
Sorry, so I think it'll be too much for a hypersensitive pneumonitis to explain everything. That's a part of interstitial lung disease. Yes, you can. But then if you have any exposure which to those chemicals, whether they are causing hypersensitivity or fibrosis, it all depends on that chemical. Okay, let's proceed.
Thanks. Coming to the investigation, complete blood count revealed hemoglobin of 14.7, total lymphocyte count of 8.8 thousand, differential leukocyte revealing neutrophil of 54.7%, lymphocyte of 38%, monocytes of 6%, eosinophil of 1.3%, platelet count was 192,000, blood urine nitrogen 11, creatinine 0.8, total serum bilirubin of 1.4, alkaline phosphatase 82, SGOT for 23, and
they are all normal.
Yes, sir, within normal. Yes, sir. Yes. So this was the first radiological imaging which we got of the child done on 16th of October, sir. Sir, shall I explain, sir? Sir, this is a chest X.
Yes, do you have any X-ray?
You can explain this, and then Dr. Vijay and Dr. Naveen can comment on that.
Yes, sir. This is a chest X-ray, AP view. Sir, it shows the bilateral diffuse in radio opaque opacities which are diffusely present, sir. The costophrenic angle appears to be acute, and also the cardiac border is also somehow obliterated, sir, in the lower end, and also the trachea appears to be a bit dilated to me, sir.
Okay,
and
Dr. Naveen.
There is some cardiomegaly and pulmonary artery evidence of pulmonary artery hypertension.
Yes, main pulmonary artery looks.
Yes, sir. Pulmonary bay is full, sir. Yes, sir.
Yeah. So I think I do agree with what you said, though I think the projection is not that great. Is it an expiratory film or inspiratory? It's not very clear, but I assume it's a inspiratory film. I
think there's some change in aspect ratios there. It has been compressed from above to below. It was
looks like
to fit in.
Yeah, but I think we'll take your points. But the trachea is dilated. That's interesting. Actually, I agree. And I think you also have your prominent pulmonary artery, and then the interstitial changes we can't see as well. But I think we'll take your point on it. And the heart border, which side? I think the left heart border looks okay. You're talking about the right heart border. That part, is it? Sorry, the left heart border you were talking about. The right looks fine, no? Yeah. So yeah, I think there's the interesting findings there actually. So
Dr. Vijay.
Yes, I think the changes are diffuse rather than confined to the lower zones. It's still way up there till the upper zones. Yes, of course, trachea is dilated. And the other thing is, I don't know whether it's because of projection or really its volume is bit less. The overall lung volume or number of spaces, although it's an expiratory film, but still it feels
Actually,
like
it has there is a change in aspect ratio. It needs to be stretched from above downwards. Then it will come out.
I agree with you, Dr. Kamal. This I
Yes,
have
ma'am.
seen these X-rays. Otherwise, it is certainly pulled transversely.
Sometimes the
Yeah,
residents do it to fit in that, na, they will compress a
yeah,
bit. But aspect ratio is never to be changed. Otherwise, everything gets.
yeah.
But ma'am, yes, the findings which the discussed and everybody agrees is that we
Yeah,
have a prominent pulmonary bay. So there is a pulmonary
yeah.
artery hypertension likely. The trachea looks a bit widened. I don't know. It is
And
because
even
of.
the esophagus, if you try to, see in this, a part of esophagus is seen which looks kind of
Yes, yes. And then you have
dilated.
symmetrical diffuse
That is
shadows.
a significant finding in
And
this.
and and then you have bilaterally symmetrical diffuse reticulonodular
Yeah,
reticular kind of shadows.
yeah,
do we
exactly.
have any previous X-rays say he was ill for last 2
I think
years?
he will show you whatever he has, Dr.
Yes, sir,
Malek,
Okay.
really.
No, just
because
We were
asking
anyway,
surprised
as
that,
a
yes,
very
we too were surprised that the child was not carrying any radiological evidence, but
okay, fine.
no, it happens. They get a bag which is lost while on the way to the hospital.
Yeah,
So many things can
exactly.
happen.
They came from Gujarat and they did not bring those old X-rays, when the TB was treated. And the subsequent thing is when they came to
So
their.
what we do at our center, ma'am, we request them to go to a hospital near to that place, ask somebody to take pictures on that view box and send WhatsApp them, so they don't have to bring the physical pictures. But that way we are
No,
sometimes
they
able to
didn't
track.
have it with them. They had
Oh,
lost
okay,
them
okay,
long
okay.
time ago. Yeah.
Telephone, we
So that
also
happened long
follow up.
time,
Yes, sir. Yes, sir.
But one
So,
thing is for sure that the X-ray doesn't look like a post-TB X-ray, does it?
yes, not very. There are no big cavities. They're still, at least on an X-ray, which is not as sensitive to pick up things like bronchiectasis. It
Yes.
you may miss. So on chest radiograph, fine. I think Dr. Kalsa, you can proceed.
Thank you, sir. Moving on to the chest imaging, sir. CCT thorax, sir. Moving, sir, cranially to caudally. Contrast film, sir. Mediastinal window, sir. There is some esophageal dilatation, sir, and there is also pulmonary artery evidence of pulmonary artery hypertension. Pulmonary artery is dilated, sir. There are also some lymph node are also seen which are calcified, sir.
Mhm.
Okay. Dr. Naveen, anything that you.
Yes,
We've not seen the lung windows yet.
yes, sir. Yes, sir.
So on this, I think wanted to ask, because I agree the esophagus was very dilated, the pulmonary artery was dilated, but the esophageal wall thickness, which seems normal here, things like eclasia cardia, they also have a very dilated esophagus, but then you have very thick wall in that. But here, I think the wall is not thick.
It's quite thin actually, yeah.
Otherwise, eclasia cardia is some, but in that eclasia cardia, you will have difficulty more with liquids than solids. So we can move on to the lung window, Dr. Khalsa.
Yes, sir. Thank you. So moving to the lung window, again moving cranially to caudally, sir. So here also we can see that bilaterally peripheral areas there are areas of honeycombing in bilateral peripheral lung field and also evidence of ground glass opacities. There is architectural distortion, sir. And there is a thickening of fissures, sir, interlobular fissures, and exuberant honeycombing is there, sir, which is more evident in dependent areas. We see that in coronal section, and the lower lobes are primarily involved, sir. May I show
So,
the
Dr. Naveen, your
select
take on this.
Yeah, I think it really interestingly fits in with the clinical presentation, isn't it? And what your clinical findings really very lower lobe involvement, though there is diffuse this thing, but I think very significant lower lobe involvement with honeycombing
But
and
I
really
think it looks as if the middle lobe or the lingular lobe is kind of spared, but you
yeah,
have involvement in the upper lobe as well as
there
lower
is
lobe.
but I think the lower lobe is significantly involved, isn't
Yes,
it?
it is much more. But now look at this.
Yeah, there is a bit. Yeah.
There is an upper lobe involvement here, but then
There
middle lobe is kind of spared,
yeah.
and then you have very clearly demarcated lower lobe abnormality. So it's upper lobe and lower lobe. which is there.
I think the periphery part of the lung is predominantly involved in
Yes.
the central part with
And
some subpleural
yes, and we
cyst.
can see a bit of fibrosis, also fibrotic bands. So it's probably okay. Fine, Dr. Khalsa, let us proceed further.
Yes.
One finding in your was a hemoglobin of 14.7. Dr. Khalsa, how do you explain that?
Sir, it could be explained due to per se now, exactly I'm thinking it could be per se due to chronic hypoxia, sir,
Absolutely, absolutely. That's the more likely explanation here.
for this. Yes, sir. So in the sagittal reconstruction also we can see GGO, sir. Per se, we also discussed this case in our with our pulmonary radiologist, sir. So ma'am was also the opinion that although there are lymph nodes, but there is no evidence of necrosis. They are calcified and also not quite enlarged. So she was very less convinced regarding the diagnosis of post TB sequelae and
So
bronchiectasis.
my take on that would be that it would mean more like an acute. If you have an acute tuberculosis, you may have those necrosis and all. But if you're looking at a sequelae, it will end up as calcification. The lymph nodes at times may not decrease in size, may slightly reduce in size, may increase. All that can happen in TB with treatment appropriately treated. But if suppose it is a sequelae, you may not have all those necrosis at that stage. It will only be calcification that you see. So this all could be large cystic bronchiectasis in more than one lobe. It is predominantly the lower lobe, but after that upper lobe, a bit in the middle lobe, and a calcified lymph nodes. I think in a country like ours, it still can be explained with something like a TB which has caused a lot of damage. Dr. Naveen.
I would agree with that, but I think I just wonder if it fits in with any other pattern of interstitial lung disease. Really, such a diffuse.
Yes, we need to look at that. Yes. Dr. Vijay?
Yes, like the lesions are mostly peripherally located and being spread through airway, the more damage may be near the central part and cavitation along with the bronchus. So it's all periphery and they all very small cyst with fibrosis, which is diffuse all over the lung with septal thickening. So that is less likely explained by your tuberculosis or TB sequelae.
But
I
rather, I would tell
agree.
you, in non-specific interstitial pneumonitis, subpleural space is the one which is paired. In non-specific interstitial pneumonitis, subpleura is paired. So that is one thing about radiology in a non-specific interstitial pneumonitis. Now we have Dr. Mini Singh also. I will take her help also. Ma'am has been my teacher, and she is very good in clinically. So, ma'am, your
No,
words
I
of
was
wisdom.
because there is associated esophageal changes and dysphagia. I was thinking of systemic sclerosis or things like connective tissue disorders or maybe a mixed connective tissue disorder. Although there is no joint involvement, there is no rash, and there's no ocular involvement as well. But just that picture of esophagus and presence of dysphagia, I thought that there would be some esophageal problem there. And with this kind of interstitial finding, one can think of systemic sclerosis. There are different forms, actually. Sometimes you don't get the total spectrum.
Absolutely.
That would be something. So it's a secondary kind of ILD, which can be thought of in this particular.
Agreed, ma'am. So what I meant was that if you look only at radiology, this is something that looks more like TB. But in the overall clinical picture here, you cannot ignore all those things that which are beyond this. So yes, we have to think
TB,
of
of
all.
course, the initial thing which was treated for 3+ bacilli being positive, Nikshay ID being there, and that somebody had treated TB seriously. I think, but that was long time ago. And TB once treated, I mean, it may have just gone away. And the subsequent fever that he developed and people treated him with recurrent TB was actually this disease which was developing.
Yes,
So
ma'am.
that
Had
would be.
a similar case during my residency program. Just we'll see what is it's coming out.
Hmm.
Just exact similar picture except the dysphagia. Let's see.
Okay.
Okay. So I think let's proceed, Dr. Khalsa. There
Yes,
is
sir.
one question about carinal angle on X-ray. There was a
Sir,
comment in
yes,
Dr. Khalsa. Can you show me the
yes,
chest X-ray? There was a comment
yes,
that is it a wide carinal angle?
fine. So,
What is your take? Is it a wide carinal angle?
sir, per se, I feel like it's splayed, sir. It's around about roughly coming out to be 80 to 90 degrees only.
So basically, 90 is what we say. Beyond that is widened angle. Not very clear. As I said, na, there is a change in aspect ratio. So that's why I'm not very sure. But otherwise, it's not beyond 90. If you look at the right, and it will be somewhere around
Do
90.
you
But
have a skygram in the CT where you can see what is the picture like, on the
Uh,
CT scan? Did you only showed the video, which is transverse cuts?
Ma'am,
So yeah, yeah.
we have one more X-ray with us. This is a beam swallow that will come later on, sir, ma'am.
Okay, all right. Okay, so he has something else to show
go
Yes,
you
with
actually.
go with
yes,
your usual presentation.
Yeah,
Let's.
so this is actually not
yes.
that text. So
For these investigations per se, also we did a barium swallow studies, ma'am, on 20th of
mm,
October, which revealed gastroesophageal junction narrowing with delayed passage with proximal esophageal dilatation, and also query eclasia possibility was kept, although there was no stricture. And this phenomenon right here is kind of rat tail like appearance per se. And we also consulted gastro fellows of ours, and they were of the opinion that we should get esophageal manometry done, and that is planned later on.
Okay.
Yes.
Okay.
So coming on to the infective workup, we repeated our workup for gastric aspirate CBNet and sputum CBNet, which came out to be negative. MGIT was also later reported to be negative in the follow-up. CRP was 12 mg per deciliter, and urine RM was with normality. Blood culture was dry. Coming on now to the rheumatological workup, ANA was negative. Extended ENA profile we sent at this point of time, which later out came out to be 3 plus anti-RO 52 antibody positive. We also did a nail capillaroscopy to find out whether, if at all, it's Renault fulminitis primary or secondary nodes, and which revealed that there were areas of capillary dropout, hairpin loops, and areas of hemorrhage. Rheumatoid factor was positive in this case, however, and also we get an echocardiogram done to look for pulmonary artery hypertension, which revealed severe PAH with mild TR and with left ventricular ejection fraction of 55%. Uh, Surprisingly, the child was not able to do PFT twice, so we have planned FOT for this child later on. Coming up to the diagnosis, we made the diagnosis of interstitial lung disease with possible rheumatological query, autoimmune etiology, connective tissue disease related ILD with Reynolds phenomena with severe pulmonary artery hypertension. So for this, we gave the child sildenafil for severe PH. Birfenidone was added as an antifibrotic agent, and prednisolone was given for ILD exacerbation, and child was discharged on oxygen therapy, home oxygen therapy. In the follow-up, after 2 weeks, the child was readmitted for increase in shortness of breath, where chest X-ray was repeated and extended. Nucleic acid profile came out to be anti-RO52 antibody positive. We gave methylprednisolone pulse for 3 days at 20 mg per meter square per day, followed by oral continuation phase. And also we added mycophenolate mofetil, and child was discharged on home oxygen, and sildenafil and pirfenidone was continued. This was the chest X-ray for which the child came back to us. As we can see that this child chest X-ray has worsened per se. The infiltrates have increased during this time, and there is also rest findings are similar to the previous finding. Our future plan for this child will be to get diffusion DLCO done. We have planned lung biopsy if there is no response, but per se the child is showing response, and also esophagus manometry to rule out whether it's eclasia, characterize it, and we have also added calcium channel blockers, and also BAL is awaited because the patient didn't give consent initially. We also plan to do BAL and get out of the dilemma that whether occupational exposure was really significant or not. So,
Fine. So thank you, Dr. Khalsa. I think we have had a very nice, good case presentation. Dr. Naveen, if suppose you had been in their place, what different would you have done?
No, I think all the steps we've followed, I think a good history and clinical examination. I think investigative workup, I think was pretty spot on. I just wonder, I think whether this could have been picked up a bit earlier. I don't know where the child was first seen. So whether a CT was done much earlier, I think that's one thing. So I think that's something which probably would have changed the track a little bit in this child. But I think at your center, I think you've done all the right things. So I think the workup was generally quite good, I would think. So I think your differential is your final diagnosis is interstitial lung disease and pulmonary hypertension secondary to Sjogren's syndrome
Yes, sir. First possibility.
Fine.
Yes, sir.
And TB as a second hit, is it?
TB was there definitely. Yes, sir.
Yeah.
TB as secondary.
Yeah.
Dr. Vijay.
Yes, this antibody positivity and what are the findings you find in CT? Are there a described entity or it is somewhat different? Are there any other interstitial disease to be thought of? Something like sarcoid?
Uh, Sir, we for yes, ma'am.
Yes, Dr. Vijay, please finish.
Yes, sir. Whether it's a described entity or it is like something sarcoid, which can also have the case which I mentioned, it was fully peripheral. It's fully peripheral lymphoma and some septal thickening and subpleural cyst, which we had earlier. That was proven by biopsy in our case. So just asking whether have you evaluated for that also? Although
So
this
your
antibody
diagnosis was sarcoidosis.
No, I'm not telling it is sarcoidosis. I'm
No,
just
no, in
asking
your
whether.
case. In your
Yeah,
case.
that in our case, similar picture with bilateral pneumothorax and recurrent pneumothorax, all cystic
Yes. So
lesions.
what I think
Usually, I think I would just like to put in here that in sarcoidosis, we usually have lymph nodes, hilar lymphadenopathy is quite prominent, and then other associated things are not there. But this NTRO52 antibody that can be positive in several conditions such as Sjogren's syndrome, systemic sclerosis, and even systemic SLE. Also, it can be positive. So it is, but more positive, I think, with Sjogren's syndrome. And so one has to see how this child behaves on the treatment that has been given. And otherwise, all form of subacute cutaneous lupus erythematosus, etc., they can have anti-RO52 positive.
Yes, thank you, ma'am. And there are two things
Mm.
that come to my mind nowadays. Many of these things, systemic sclerosis, mixed connective disorders, all these things may have manifestations which will come up later at a different age.
Yes,
You
exactly.
at this young age, you may not have all the dots to
Yeah,
connect,
yeah,
which may come on
exactly.
later. But the child has one manifestation which is clear and there. And I think with this time of genetics coming up, if we have a good differential diagnosis, and whole exome sequencing to an extent can help us pick up something which clinical examination may not be able to help us, because there are findings which are not expected at this age, which will come later. So in an adult, probably they will be better off in making a clinical diagnosis. But here, that is something that we can think of. Given another thing that can help us is probably a lung biopsy, because my take, as Dr. Khalsa said, that if he doesn't improve, we'll do it. My take is that if he goes beyond a point, then you will not be able to do a lung biopsy. Till he is able to manage saturations well, it's a good time to do a lung biopsy and get a diagnosis. Once his oxygen requirements increases further, he may not be a good candidate for a lung biopsy. So,
But
but I
lung
think
biopsy also will show only the fibrosis, and it will show interstitial lung disease. It will not make a diagnosis whether this is ILD, which is secondary to some of these underlying disorders, or it is this positivity of this particular marker is there with interstitial lung disease. Sometimes pure interstitial lung disease also can be positive, but the progression of the case has been more like a chronic evolution. So I think, and then slow development of pulmonary hypertension, all these things go more in favor, and presence of esophageal dysmotility. I think all these go more in favor of collagen vascular disorder rather than, and this being secondary, the ILD being secondary to that.
I think, ma'am, with you being at the hem of affairs, this child will ultimately, we are sure that he will get the right diagnosis. But I think a great case to discuss. There were a lot of learning points for me, and I think the lead discussants, they will have to say. But how did they find this case, Dr. Naveen? How was your experience?
No, I think it's a very challenging case. I think there are multiple clues right in the history as to, I mean, the diagnosis went in different directions, isn't it? So,
Yes.
but getting
Actually, we are always very worried about tuberculosis
yes,
because, and many times, we forget other diseases. Although
Yes.
TB is very common, and this child probably had tuberculosis at one stage of his life, but
Mhm.
later on he had this other disease which is more central to his current disability. So I think that is something, and we really have to find out the markers and to see whether any of these antibodies, these newly discovered antibodies, and all the Zumabs, which one will be effective in this particular case.
Mhm.
True, ma'am. Dr. Vijay, any last comments?
Yes, sir. It's challenging case really. All I want to know is whether this antibody positivity with this lung picture, they are like compatible, or they are already described entity, or it is something
Dr. Khalsa, this is
new.
the last question from Dr. Vijay to you.
Yes, sir. Sir, there has been since anti-RO 52 antibody was strongly thought to be positive, and there has been literature which supports that anti-RO or SSA positivity associated with higher frequency of interstitial lung disease diagnosis in various autoimmune diseases, and also it offers a more severe and early involvement of lung per se. This has been found out in this recent systemic review and meta-analysis, and also it has been associated as a poor prognostic marker.
Mm.
So this has been shown in although literature is of adult, but pediatric literature is scarce in this regard. And also coming to the point that also there have been studies which say that in although for ILD umbrella treatment would be starting methylprednisolone first, followed by steroid and mycophenolate mofetil, and also rituximab has also shown promising results. And literature is coming up regarding that rituximab as only has been approved as an add-on therapy in these cases.
I think, thank you, Dr. Khalsa. I think this answers Dr. Vijay's question. I'll now come back to Dr. Minu Singh for any last comments, and then we, I think, wind up the session. We have had a very good
Yes.
discussion. It was a roller
I
coaster kind of
think
a ride.
hypoxia will also need to be corrected because the child is developing pulmonary
Absolutely.
hypertension. And
Absolutely.
once that
Child is
exceeds
on
a certain
ventilator.
limit, the child will develop right-sided heart failure.
He
So this,
probably home oxygen is also
Home
something
oxygen,
that
yes,
yeah,
sir.
home
Child is on home
oxygen is
oxygen.
something which is really needed for him. Yeah.
We agree via concentrator. We agree.
Thank you so much, ma'am. And
Okay,
thank you,
thank
Dr.
you.
Naveen, for the excellent inputs. Dr. Vijay for coming in. Dr. Minu Singh, ma'am, she is my teacher, so I've got an
Thank
opportunity
you.
again to learn
Thank
from
you.
her.
I really liked the way you moderated, Kamal. Thank you so
Thank you,
much.
ma'am.
Yeah.
And I'm back to Dr. Sanjeev Singh Rawat, sir. Thank you from my side.
Thank you very much. So, Dr. Manmeet, you have presented a case in a very excellent manner. You have done a wonderful job in giving us very good details about the case, and your exemption findings and all your discussion was really very good. I think this case demonstrates amply that lung disease can be caused by diseases outside the lung. So systemic diseases, there are a lot of disease which can cause problem in the lungs. So secondly, you could have symptoms of diverse uh, environment, like sometimes GI tract and skin and joints and vessels. So if you try to connect all the dots, then definitely you can reach to your then a diagnosis. TB sometimes TB in a country it can be associated because TB itself cannot explain all the disease. So there could be TB and there could be underlying disease also. So I think out of the box thinking and trying to widen your questioning of the child and taking a very detailed history, I think it pays good dividend. And this case is an ample example of a very good history and examination can reach the dividends. I thank Kamal sir for an excellent moderation, Naveen sir, Dr. Vijay, and of course Dr. Minu Singh for mentoring this case so well. And there is a lot of learning points in this case, and I hope all the delegates who are on board today evening, they must have an excellent time. So, thank you very much. Good night. Till we meet next month for the last session of this year. Thank you very much. Good night and goodbye from IPNRC. Bye bye.
Okay.
Thank you,
Good
sir.
night.
Thank you.
Thank you. Thank you.
Thank you, everybody.
Thank
Thank
you,
you.
everyone. Thank you. Thank you, sir.